Now I invite Dr. Harjit Dumra, sir. He will talk on how I do my day-to-day decision making in pulmonology OPD. Dr. Harjit Dumra, sir, is a consultant pulmonologist, critical care and sleep medicine specialist. He is a director of Sports Chest Disease Center. He is a teacher of DNB critical care and IDCCM fellowship programs. And his area of interest is pulmonary critical care medicine, lung transplant and interventional pulmonology. Over to you, sir.
Thank you. Thank you for having me here. Rajkot is always a good place to come to, and it's been some time, so it's like a homecoming for me. And I'm going to keep it very basic. The dictate given to me was this has to be day-to-day, this has to be practical, this has to be implementable. So this is what I do in my day-to-day practice. And I'm going to focus on obstructive airway disease primarily because that is where most of your OPD patients will be seen. So I'm going to use the vignette of a case. This is a lady who came to me around 52-year-old. She's been exposed to biomass fuel for the last 20 years. Now she started having breathlessness with very little effort. She has a history of recurrent rhinitis. She has her mother had asthma. And as a child, she had frequent bronchitis. No longer having bronchitis, there are some comorbidities there, as you can see. She is hypertensive, she is diabetic, she is obese. She comes with an ECG and an echo, as most of our patients would have been through those two investigations before they come to us. The ECG is reasonably okay. The echo shows some diastolic dysfunction. Her room air saturation is around 94%, and we do a spirometry on her. And this is the result we see. Her FEV1 is very low, and this is the ratio which we commonly see. We also do a reversibility test, and this, I'll come back to this, is partially reversible. Now, whenever we look at a spirometry, that has been a limitation for most clinicians and physicians because they are not easy to read it. So many of you either don't do it, many of you either do it but don't interpret it. And that has been the problem with diagnosing airway disease. So rather than complicate it too much, we need to look at only two parameters as far as the basics go, the FEV1 and the FVC. What are those parameters? We'll come back to a little later. But this is the lady sitting in front of me, and she has breathlessness. And there is this list of differentials. She is middle-aged, she has comorbidities, and she comes with breathlessness. And obviously there is a list of conditions which I can think of might be the cause of her shortness of breath. Now, just setting the ball rolling, the commonest cause would be cardiovascular or pulmonary. And by and large, when you look at those two etiologies, some basic clinical findings will give you a clue whether this is cardiac or respiratory. The spirometry, obviously, this spirometry also has a BMI. So sometimes we do not calculate the BMI in day-to-day practice. We believe a patient is lean and thin, but nowadays we've seen that there is something called normal weight obesity also, and hence a BMI and maybe a waist circumference should be done in day-to-day practice. A pulse oximetry is very commonly asked, can be done, and an ECG. Almost 50% of your patients with this and along with the chest X-ray will give you a diagnosis of breathlessness. Once you have some suspicion of what the disease is, you can go for advanced investigations which could include a CT, an echo, and so on and so forth. But a spirometry, ECG, pulse oximetry, and chest X-ray, 8 out of 10 times you will get the diagnosis as to whether it is primarily respiratory, primarily cardiac, or a mix of two diseases. More often than not, dyspnea is usually not a single entity. It's a combination of so many factors. And many times we are so focused on treating just one etiology that the patient does not get better from the symptom which he came to you, and you have treated only one disease. So always believe there could be multiple causes behind dyspnea. You need to identify each and only then move forward. Now, the commonest causes as far as respiratory system goes, because this patient came with the normal ECG, the echo did not show significant findings, so obviously the thought process was respiratory, is asthma and COPD. Now, there are guidelines and there are statements which will tell you what is the definition, but I'll show you what is the problem with the definition. Both these diseases are heterogeneous. Both these diseases are associated with common respiratory symptoms. So you cannot differentiate between asthma and COPD on the basis of symptoms. The only difference is on the objective testing, where one, that is asthma, will show you variable airflow limitation, which means airflow limitation might vary from day to day to week to month. And in COPD, you will have the same level of airflow limitation. It will not change. Now that is the only difference between these two conditions. Hence, it is becoming increasingly difficult to differentiate between asthma and COPD. In fact, previously we used to believe that for you to identify a patient of COPD, you have to be exposed to some noxious trigger. There should be history of smoking, biomass fuel exposure, some occupational exposure, air pollution exposure. But now, there are other risk factors which can lead to COPD. So even patients who have had no noxious exposure, have had childhood respiratory illness, have had prematurity, have had an environmental exposure as a child, can still end up going to develop COPD. So it is not mandatory that a COPD patient should have some exposure. Even frequent infections as a child, prematurity, genetic disorders can lead to COPD. And that has complicated the division between asthma and COPD. Because previously we believed if you don't have an exposure, it is asthma. If you have an exposure, it is COPD. And that is why it's not easy on the basis of this differentiating criteria to classify these two disorders, but this is the general difference between the two conditions. Usually asthma can start early, there will be a family history, there will be a background of allergy, there will be variable airflow limitation, and there will be a normal X-ray. In COPD, there will be exposure to noxious triggers more often than not. This will be a middle-aged to an elderly person. The X-ray will show hyperinflation, and there will be a fixed airflow limitation. There will be persistent dyspnea on exertion. It will not be seasonal, it will not be episodic. So the history does point to some way to identify these conditions, but like I said, it's getting difficult all the time. So some patients of asthma can be smokers. Some patients of asthma can have occupational exposure. Some patients of asthma might have neutrophilic inflammation, and some patients of COPD can have allergy also. Some patients will have reversibility. So it's not easy with that classical definition, and hence there is this overlap between asthma and COPD in quite a few patients, now which we know as asthma COPD overlap. In fact, 50 to 60% of the patients which you commonly see in day-to-day practice will have some features of asthma, some features of COPD, and the airflow limitation might be anywhere between normal to significantly limited, and they fall into this broad category of asthma COPD overlap. Now, why is that relevant to practice? I'll come back to a little later, but what is important to today's discussion is that it is getting more and more confusing to differentiate and classify airway disease into asthma and COPD, and 9 out of 10 clinicians sitting here treat it the same way. You hardly identify a patient of asthma or COPD, you treat it the same way because you cannot do it in day-to-day practice. So this is where science has evolved, and this is where we are going towards. So now we do not, in many circumstances, classify patients as having asthma, COPD. We look at what is called treatable traits. What are these treatable traits? All our patients of airway disease have some common components which have to be addressed when the patient comes to you. Now, if the patient is already on therapy, these are some behavioral traits. You have to look at the fact that the patient is taking the inhaler regularly or not, whether the patient is smoking or not. You can look at other comorbidities which contribute to the breathlessness. It could be anemia, it could be rhinosinusitis, it could be anxiety, it could be overweight. And they will remain same whether it is asthma or COPD, and you can treat that trait. Very importantly, the airway inflammation previously in asthma was believed to be eosinophilic, and in COPD it was believed to be neutrophilic. It's no longer the case. COPD can be eosinophilic, asthma can be neutrophilic. So depending on the kind of inflammation, regardless of the label of asthma, COPD, you treat accordingly. So you have certain drugs which treat eosinophilic inflammation, the inhaled steroids, and there are certain drugs which treat neutrophilic inflammation like LABAs and LAMAs. So regardless of the label, you treat the trait rather than the disease label. And this is where we are moving forward to. So how do I confirm diagnosis? Well, that is not very difficult. We look at what is called a spirometry. This is the normal spirometry loop, and we look at two important points, like I said, FEV1 and FVC. What do we look there? The first and foremost is to differentiate whether the loop has obstruction or restriction. So if the FEV1 by FVC ratio is less than 70, it confirms obstruction. Anywhere more than 70, it is normal or restriction. The second thing you look at, how severe is the obstruction, and I'll come back to that. And the third thing you look at is it reversible or not? These are the three things which as a physician you need to understand to have basic interpretation differentiating asthma and COPD. By and large, asthma is considered to be reversible. By and large, COPD is considered to be irreversible after a bronchodilator challenge, but again, there are caveats to that. Sometimes you don't need to look at numbers, you only need to look at the graph. So if you have a very concave looking graph like this is very classical for airway disease or obstructive airway disease. In restrictive diseases, you have this entire loop which is smaller than normal. So just looking at the loop, you can decide whether it is restrictive, whether it is obstructive, or whether it is normal. Pulmonary fibrosis is the commonest restrictive disease. Asthma and COPD are the commonest obstructive disease. So just looking at the loop also will give you some idea. Then we do what is called reversible testing, where we give salbutamol to the patient in the nebulizer or in an inhaler, and we recheck for improvement. In patients with asthma, by and large, there will be significant improvement, which is labeled as greater than 200 ml and 12%. In COPD, as you see, post-bronchodilator, there is hardly any reversibility. So this is one way to differentiate between the two conditions. However, you can have asthma without reversibility, and you can have COPD with reversibility. I'm not going to confuse you with that because we are going to focus on the basics. When about severity, something new has come up. Previously, we used to look at numbers, 60%, 70%, 80%. Now we look at what is called Z-scores. Z-scores are basically standard deviations of 5% from the baseline. So if you have 5% deviation, you will have more than around 1.65 from normal. If you have moderate disease, it is 0.25 away from the midline. And if you have severe disease, it is greater than -4. And luckily for us, the newer machines give us the Z-scores. So you don't need to even interpret it. There will be a number coming. So if it is greater than 4.5, it is severe disease. What about diffusing capacity? It tells us about the gas exchange area in the lung. That is the interstitium, as you can see. This is where gas exchange occurs. And usually in patients with interstitial lung disease or pulmonary hypertension, we look at diffusing capacity. There are other conditions which can give rise to low diffusing capacity. So if the oxygen carrying capacity of the blood is low, like in anemia, if the patient has a blood clot in the lung, like embolism, these patients can also have low DLCOs. Again, there is a number given as to how severe is the DLCO reduction, and based on the severity, you can prognosticate the patient. So the more the reduction in the DLCO, more severe the disease, worse the prognosis. So just look at the numbers and you can still assess the severity of the disease. Are there any new techniques to help you out? Sometimes when the patient has normal spirometry and we suspect asthma, we send the patient home with what is called a peak flow meter, and they check readings from morning to evening. If there is a 20% variability in the reading over a period of weeks, that is one classical sign of asthma. So even patients where we cannot differentiate clinically on the first day, we can do it later on. We look at what is called a pheno, where you blow into a machine and the machine tells you whether the patient has eosinophilic inflammation or not. So it is a classical marker that this patient might respond to inhaled steroid. We look at what is called lung oscillometry nowadays, where we look at small airway disease because that is sometimes a dominant component. And we also look at CT imaging parameters occasionally to help us differentiate between asthma, COPD, and other diseases. And these are some of the recent advances. Like I said, let's come back to this case. What was the patient's cause of breathlessness? This patient had undergone reversibility testing. It was significant reversible. The DLCO was around 63%. He had high eosinophil counts, and the CT showed scattered area of bronchiectasis. Clearly, this data did not support either asthma or COPD, so this was some kind of an overlap disease. But this patient also had other factors contributing to breathlessness. She could have had a HFpEF, she was obese, she had physical deconditioning, and she had sleep apnea as well. So all, it shows that this patient had multifactorial dyspnea, and most of your patients in the OPD will have more than one reason for shortness of breath, and unless and until you address each aspect, you are just treating a label, the patient is not going to get satisfied. So always look at multifactorial etiologies when you look at dyspnea. What about treatment initiation? There are two groups of drugs which we commonly use in patients with obstructive airway disease: the inhaled steroids and the inhaled bronchodilators, and we have a list to choose from. These patients, these drugs are also available in the combination form. You can have a combination of two bronchodilators, the long-acting beta-2 and the long-acting antimuscarinic, and you have a combination of long-acting beta-2 and inhaled steroids. Now, we also have triple drug combinations available to us, where one inhaler will have all three drugs: inhaled steroid, inhaled long-acting beta-2, and inhaled long-acting antimuscarinic. Now, once you have labeled a patient as asthma or COPD, which is important in day-to-day practice because the prognosis of these two diseases is very different, you have to decide which is the best drug for this patient. Now, there are two guidelines which we commonly follow to manage these patients. The asthma guideline comes from GINA, and this gold guideline gives us directions for COPD. The asthma treatment of choice is a combination of inhaled steroid and long-acting beta-2. Formoterol budesonide is the drug of choice. So if you want to remember one drug to treat asthma, it is formoterol budesonide. It is very simple. You start with SOS treatment if it is a mild disease, or you start with regular treatment if it is a daily disease. You can start with 1 puff twice a day. You can build it up to 2 puffs twice a day. You can increase the dose of inhaled steroid. In COPD, the drug of choice is not inhaled steroid. In COPD, the drug of choice is a combination of bronchodilators, LABA and LAMA, and this is the 2025 guideline. So formoterol glycopyrronium becomes your drug of choice for COPD. Formoterol budesonide becomes your drug of choice for asthma. So if you want to remember just one drug out of those entire list, these are two drugs which you can practice safely with. So what I have told you till now, I'll summarize with a few key points. Try and identify the specific cause of dyspnea from basic investigations: chest X-ray, pulse oximetry, ECG, and X-ray. It should be classified into cardiac versus respiratory. If spirometry, you divide it into obstructive versus restrictive. If obstructive, you classify them into these three causes. Initiate treatment. If it is asthma, it is ICS plus LABA. If it is COPD, it is LABA plus NAMA. And if it is an overlap, you combine all three drugs, and then you monitor response to therapy. Coming to how do you choose the device, and I'm running short of time, so I'll start going a little fast. These are the three devices which you choose from: the metered dose inhaler, the dry powder inhaler, and the nebulizer. And all of you will be using all of these three devices. What is relevant to the device? The first thing is, it's been 40 years since we started marketing devices for asthma and COPD, and this study clearly showed that in the last 40 years, our patients have not improved as far as device use goes. That means we as clinicians, we as clinicians have not improved our education skills to improve the delivery of the drug to the patient's lung. And whether it was 1990 or 2025, the errors in device use still remain the same. Around 40% of your patients don't take it rightly. And that is imperative for control of these two diseases. There is a list of errors which most of these patients perform, and the wrong technique gives poor delivery of drug, leading to poor control of disease. Hence, it is very imperative that before you increase the dose of any drug, before you change the drug, before you add on therapies, please remember, check the device use every time the patient comes to you. The inhaler techniques have to be emphasized. There are videos available. I can give you links for that. But remember that you have to know how to use the device for you to teach the patient how to use the device. And unless and until that happens, our patients will never improve because the teaching and the time spent on device education is extremely low. A lot of you use nebulizers. I'll just tell you that the prescription of nebulizer is getting over and overused simply because it is the easy way to deliver drugs. However, there are too many caveats there. I'm showing you 1 month cost of therapy when you prescribe nebulizers to your patients versus inhaler. And there is a huge cost difference. And there is no data to suggest that in the right group of patients, prescribing inhaler, dry powder or MDI is inferior to nebulizer. Nebulizer doesn't work for you if it is given in the wrong patient. Per month cost of therapy differs by 4,000 rupees. You can very well imagine prescribing 1 year of therapy, loss of 50,000 rupees without additional benefit. So choose your drugs and nebulizers very, very religiously. The best nebulizer to use today is the vibrating mesh nebulizer. It is no longer the jet nebulizer. So if you are making your patient invest, that is the device to go with. How do you choose the device? There are several ways to do it. The most important is to show most of the devices available. Check which is the patient preference. Check whether the patient has the ability to use this. You also have to understand that in India, we have the luxury of all molecules being available in all devices, but in certain countries, certain molecules will be available only with certain devices. So you will have to depend how to choose the device based on the drugs available. You also have to look at the cost of therapy. You also have to look whether the insurance is reimbursing. You also have to look at whether the patient is comfortable with the device and is it the preferred device. Do not use multiple devices in the same patient. Prefer to give him one kind of device which delivers all the drugs so that he doesn't get confused using different devices. This is the link which you can use if you want to teach your patients how to use the devices. These are freely available on the net, and simple links will tell you the best way to use them. I've already emphasized on the misuse of the nebulizer. Please don't use it unless and until it is definitely indicated. Also remember that today we are looking at a green revolution, and every inhaler you prescribe adds to environmental pollution. So dry powder inhalers are better than metered dose inhalers because we are looking at a green revolution. So if possible, try to look at that aspect when you prescribe, because every inhaler contributes to global warming, and there is a lot of emphasis on this as well. So in spite of using the right device and the right drug, in spite of that, if your patient is not doing well, please do not jump. Check the compliance of the patient. Check the inhaler technique. Many times the patient will still be smoking. Many times the patient will still have occupational exposure. Check the impact of comorbidities. Check the activity levels, because a lot of patients will have physical deconditioning contributing to breathlessness. Always remember, rehab goes a long way in improving the condition of your patient. And always remember, vaccinate, vaccinate, and vaccinate. Basically, these 5 points should take care of most of your problems when encountered that a patient is not responding to therapy. I hope I've made some things clear, and I'll be open to questions. Thank you.
Thank you very much, sir, for sharing your practical expertise on talk. And now
the session is open for question and answers. From the audience, if anyone wants to ask the question, then come to the mic 1 and 2 for the questions. We can take 1 or 2 questions as we are closing the session by 11:30.